Welcome to Mastering Section I, Active Diagnosis on the MDS Assessment. In this video, we'll help you identify the various components of Section I, understand the coding instructions, accurately complete each item, prevent common coding errors and misconceptions, and recognize the impact of Section I on care planning and resident outcomes. The items in this section are intended to code diseases that have a direct relationship to the resident's current functional status, cognitive status, mood or behavior status, medical treatments, nursing monitoring, or risk of death. One of the important functions of the MDS assessment is to generate an updated, accurate picture of the resident's current health status. Our section begins with item I0020, indicate the resident's primary medical condition category. For this item, we will be identifying the resident's primary medical condition category based on the condition that is chiefly responsible for the resident's stay in the facility or for the skilled services being provided at the time of assessment. Before completing this assessment, it is important to understand that this item reflects the primary reason for the resident's current admission or skilled stay, not the most severe diagnosis, and not necessarily the most chronic condition. Our assessment for this item will include reviewing the admission diagnosis, hospital discharge summary, physician documentation, therapy documentation, and current plan of care to determine which condition is primarily driving the resident's need for care at the time of assessment. Based on our assessment, proceed to select the appropriate primary medical condition category from the available coding options listed in the item set. The next item set found in this section will be I0100 through I8000, active diagnoses in the last 7 days. For this item set, we will be utilizing a two-step process which will involve diagnosis identification and diagnosis status. To identify diagnosis, we will begin by reviewing various medical record sources such as progress notes, the most recent history and physical, transfer documents, discharge summaries, diagnosis or problem list, and other resources as available for physician-documented diagnosis in the last 60 days. Once a diagnosis is identified, our next step will be to determine if the diagnosis is active. Active diagnoses are defined as having a direct relationship to the resident's current functional, cognitive, or mood or behavior status, medical treatments, nursing monitoring, or risk of death during the 7-day look-back period. To fully understand how the diagnosis is affecting the resident, it is important to review all available sources of information including physician progress notes, problem lists, hospital discharge summaries, nursing documentation, medication administration records, therapy documentation, lab results, and care plans to determine which diagnoses meet the criteria for being active during the 7-day look-back period. Based on our assessment, we may now proceed to code yes for all active diagnosis, or no for inactive or resolved diagnosis, listed for the major disease categories between item I0100 to I6500. If no active diagnosis were noted during the 7-day look-back period, proceed to I7900 and code yes for none of the above. If a disease or condition is not specifically listed, enter the diagnosis and ICD code in item I8000, additional active diagnosis. While examples of diseases might be available alongside some of the disease categories listed throughout this section, it should be noted that conditions are not limited to only those listed in the examples. For example, item I200 anemia includes anemia of any etiology, including those listed as an example. It is also important to note that select items in this section may have their own particular set of coding guidelines. For item I2300 UTI, the look-back period will be 30 days for active disease instead of 7. We will also only code this item if both of the following are met in those last 30 days. It was physician documented and determined that the resident had a UTI using evidence-based criteria such as McGear, NHSN, or Loeb in the last 30 days. Item I2100 septicemia may only be coded if the medical record reflects inflammation due to sepsis and there is evidence of a microbial process. Item I5100 quadriplegia limits coding to spinal cord injuries and must be a primary diagnosis and not the result of another condition. Lastly, item I6000 schizophrenia should be coded with caution by ensuring available documentation remains in accordance with Federal Regulation Code Title 4.2 before coding. Now before we end, here are a few quick coding tips and common mistakes to avoid, directly from the RAI. For the resident's primary medical condition category, Remember, this is best describes the primary reason for the resident's stay, which might not always be the most severe diagnosis, or necessarily the most chronic. Active diagnosis includes nurse monitoring for medication efficacy for treatment of the resident's condition. It does not include monitoring for adverse reactions, as this is an expected and usual nursing practice for all medications. To help determine if a diagnosis is active, the reviewer would check records during the 7-day look-back period for notation of treatment of symptoms, doctor's orders for medications, and documentation of physical or other therapy for functional limitations caused by the diagnosis. Simply listing a disease or diagnosis on the resident's medical record problem list is not sufficient for determining active or inactive status. Section I plays a pivotal role identifying the resident's conditions and developing a plan of care that is comprehensive and holistic, which is why coding accuracy is imperative. For more information about coding the MDS, or to see more MDS-related content, follow our channel at MDS Made Easy. Brought to you by the Data Nurse, your partners in MDS Precision.